Hey guys, for those of you who don't know me or haven't met me, my name is Jane Belyavskaya. I'm one of the sonal faculty at Kings County, but I also finished my residency here as well as my ultrasound fellowship last year. And I'm going to be giving my lecture today on ultrasound for right heart strain. Now, why is this important? PE is one of the can't miss diagnoses in the ED, and patients who present with PE are at high risk for clinical deterioration, especially those with submassive PEs. Unfortunately, abnormal vital signs are poor predictors for mortality associated with PE. And although CT angio is your gold standard for diagnosing PE, it only has a sensitivity of 81% and a specificity of 47% for right heart strain. On the other hand, CT can help guide management in patients with acute PE, especially those with right heart strain, as focused ultrasound has been shown to detect right heart strain in more accurately than CT or serum markers, with a sensitivity as high as 100% and a specificity as high as 99% in one study. But it is also important to note that right heart strain alone is not a sensitive finding for the diagnosis of PE. Making that kind of distinction between like a PE with right heart strain versus a PE without it can help you prevent that clinical decompensation that I was talking about, and that decompensation towards cardiogenic shock and death that we see with increased RV afterload. So I'm going to be talking a little bit about kind of the more common findings that we see with on ultrasound for right heart strain, but then going into some more fancy techniques that we can use more so to differentiate in patients that have chronic right heart strain from other underlying chronic processes that come in with concern for PE and acute right heart strain. Starting off, we're going to start off with the D sign, which we see on our parasternal short view. For this view, you're going to want to be right at the level of the papillary muscles, as being above or below can cause you to have a false positive D sign. And what you're seeing here is RV dilation secondary to pressure or volume overload that causes septal bowing and the formation of what we call here a D sign. And go into more fancy things like this eccentricity index mentioned here, but I don't think that's necessary for this lecture. The next thing you can look for is right ventricular dilation. This can be seen better in your apical 4 view, where you can visualize both ventricles and compare the two. In a normal patient, your left ventricle should be about 2/3 the size of your right ventricle. So if you see that the right ventricle is about the same size as the left ventricle or larger, that should raise your concern for right heart strain and right ventricular dilation. Fortunately, there are some pitfalls with looking at the RV size. This only estimates the relative size of the RV. So in a patient who has a prior history of left ventricular hypertrophy as well, it's harder to look for kind of RV dilation. And this kind of finding is subject to error because it depends on the angle of the probe versus the RV. You'll see RV enlargement in things like PE and MI, but you'll also see it in chronic processes such as pulmonary hypertension, COPD, and congenital defects. The next thing we often teach is a McConnell sign. This is actually a common finding for an acute PE. This refers to akinesis of the RV free wall, which you see here, and normal motion of the RV apex. We sometimes refer to it as a man jumping on a trampoline, especially in a patient that's more tachycardic. This is best viewed over 3 to 4 cycles in the apical 4 view, and is more specific for acute right heart strain than the other things that I've talked about previously. It is notable to note that you can get McConnell sign with other pathologies, though, including acute elevations in RV afterload, RV infarction, or extrinsic compression of the pulmonary vasculature secondary to, let's say, like a mass. The next thing we often teach as like sonal faculty is tricuspid annular plane systolic excursion. This is best used in the setting of a confirmed PE to quantify RV systolic dysfunction, and is used as a risk stratification tool to determine the need for like thrombolytics or IR guided therapy. The way you would get this measurement is by getting an apical 4 view with a good view of the RV free wall. And you put M mode over the tricuspid lateral annulus to look at the vertical movement of the tricuspid annulus between the end of diastole and the end of systole in M mode. So you're taking a dynamic process and you're making it static in M mode, and measuring the difference between the distance between the peak and the trough, which is your TAPSE. A number greater than 1.6 to 2.0, there's kind of a debate on this number, is considered normal. So it makes sense. The less that your tricuspid annulus moves, the less that your RV free wall moves, the greater the RV dysfunction. This is not the best study. So you see that it only has a sensitivity for right ventricular dysfunction of about 72% and a specificity of 66%. So it has a lot of limitations. These limitations include that it only represents one component of RV motion, and in a patient that you're measuring their TAPSE, they can have a frankly dysfunctional RV but a preserved TAPSE. But then you can have a significantly reduced TAPSE, but the RV is actually functioning normally and is globally preserved. It's a hard view. It's a hard measurement to get because you can in your apical 4 view, you're not always able to see that RV free wall. So at the end of the day, we just use it to look for the patient's prognosis. And you can kind of use it as a way to push somebody to the IR suite, but otherwise I wouldn't use it to differentiate between acute and chronic right heart strain or to assess for RV dysfunction. The next thing that you might see when you're looking for right heart strain or signs of hypotension, or looking for the causes of hypotension, is a clot in transit. This is especially useful in your kind of decompensating patient that's about to code. A clot in transit can change your management, as it will push you to give TPA in a patient you might otherwise have not thought to give TPA in. So far we've talked about D sign, RV dilation, McConnell sign, TAPSE, and clot in transit. Although McConnell sign and clot in transit are both very specific findings for QPE, the other findings can't really differentiate between acute or chronic right heart strain in the patient with a prior history of any kind of pulmonary hypertension or chronic process. So this is when we get fancy. So here one of the things we can do is look at RV free wall hypertrophy. You can measure this in your subxiphoid view, and you're going to measure kind of the thickness of the RV free wall at its thickest point. You want to make sure here that you're not including an anterior fat pad in your measurement. And a number less than 5 is considered normal, and a number greater than 5 is considered abnormal. Just like the left ventricle, your RV can also remodel in the setting of chronic pulmonary hypertension in this case. So a thickened RV free wall suggests a more chronic process. Take this together with other findings of right heart strain, such as right ventricular dilation or a D sign. It can help you differentiate between acute and chronic processes. So a patient who has no RV free wall hypertrophy and signs of RV dilation or a D sign is more likely to have an acute process. The next thing that you can look at is pulmonary acceleration time, which refers to the time it takes for blood to accelerate within the pulmonary artery. In a patient with an acute change in their RV afterload, that number will be a lot shorter as their right ventricle hasn't had time to compensate for the increased afterload. And so although a normal number for pulmonary acceleration time is greater than 130, a number less than 60 milliseconds suggests an acute obstruction. This is a harder view to get. So for this view, you're going to want to get your personal short view and then move directly vertically upwards to get this Mercedes-Benz sign. Then you're going to put pulse wave over your pulmonary valve right over here. Then you're going to want to measure the horizontal distance, or the time it takes to get from kind of like your highest point to your lowest point here. And so that difference is your pulmonary acceleration time. And like I said, a normal number is 130 milliseconds, but a number less than 60 is considered secondary to an acute obstruction. The next thing, also kind of more complicated, is looking for the right ventricular systolic pressure, which should be equal to your actual pulmonary artery systolic pressure. This number is only you can only get in a patient who has tricuspid regurg on ultrasound. And first you measure the patient. You can put your pulse wave over the tricuspid valve to get the tricuspid jet. Oftentimes the GE will let you measure the area under the curve, so you don't have to do this measurement. And then you add your right atrial pressure to that measurement to get your pulmonary artery systolic pressure or your RV systolic pressure, because we're equating the two in this case. So in order to get this measurement, you're going to want your right atrial pressure, which your right atrial pressure you're equating to your IVC pressures. And we're going to, here we're not going to like measure the IVC, but you're going to make some estimates. So a patient with a collapsible IVC will have a right atrial pressure of 3. A patient with respiratory variation of their IVC is going to have a right atrial pressure of 8, and a patient with a plethoric IVC is going to have a right atrial pressure of 15. So once you have this number, you could add it to the area under the curve for your tricuspid jet, which will give you your PASP or your RVSP. And you want this number to be, again, less than 60. A number greater than 60, because a number greater than 60 suggests like more chronic process. Taking all that together, except for your right ventricular like free wall hypertrophy, you have come to the 60-60 rule, which maybe you've heard of, maybe you haven't, but is a useful tool to differentiate between acute and chronic right heart strain. It's especially useful in your patients with evidence of tricuspid regurg, but it has a specificity of 94% specifically for acute PE, but only a sensitivity of 25%. This is a lot of work. It's not something I do every day, but I would do it in a patient who has signs of who I'm concerned about a PE in, but has other chronic processes that might have contributed to right heart strain. So in summary, there are several signs of right heart strain that can be found on ultrasound. TT is actually more sensitive and specific for right heart strain than just CTA. But unfortunately, it's difficult to differentiate between acute and chronic right heart strain in patients with a prior history of any kind of pulmonary hypertension. So those are the cases where it might make sense to get more fancy and do things like a 60-60 sign. But I think in general, also just good to know about. Any questions?